Can you hear me? Another 3 minutes, I'll start the class. Can everyone hear me?
Yes, ma'am.
Okay, what very few people, only 31 participants. At 1 o'clock, I'll start the class. Another 2 to 3 minutes. Okay?
Okay, ma'am.
Tell all your classmates to join fast. Okay, now shall we start the class? Hello,
Ma'am.
shall we start the class now?
Yes, ma'am.
Okay, actually, previously we have talked about the anatomy of the nose and the paranasal senses. Today, the class is diseases of the nasal septum. So, various parts of the nasal septum. Anyone can tell? Various parts of the nasal septum. So there is a membranous part, the cartilaginous part, and a bony part. So the membranous part is the most anterior most part. It constitutes of the skin and the fibrofatty tissue. Posterior to this is the cartilaginous part, which is constituted by the quadrilateral cartilage and the part of the upper lateral and lower lateral nasal cartilages. And the posterior is the bony part. It is formed mostly by the vomer, perpendicular plate of the ethmoid, the rostrum of the sphenoid, crest of the maxilla, and the crest of the palatine bones. So now today we are talking about the deviated nasal septum. What is a deviated nasal septum? It is a deviation of the cartilage or bony framework of the nasal septum from the midline with some nasal symptoms. So the incidence of the septal deviations is much higher in the leptorine type of the nose found in the Caucasian races. So in those people, genetically, you will have a deviated nasal septum. Most of the people in those races. So the etiology of the deviated nasal septum is so many deviations are due to direct trauma or hit on the nose. The nose is the most prominent part of the face. Whenever you get hit to any object, first the nose is struck to the object. So mostly the nose gets injured in a direct trauma and is frequently associated with fractures of the nasal bones. So other theories are one is a birth molding theory. So it's an abnormal. So the fetus in the mother's womb lies in a universal flexion position. So the hands over the face. So sometimes this posture can cause compression of the dorsum of the nose. So leading to a deviation of the nasal septum. So abnormal intrauterine posture may result in compression forces acting on the nose and upper jaws. So that is one of the reasons. Since birth also you may have a deviated nasal septum. So when you find after birth the infant unable to take breath, then if you see there's a deviated nasal septum, you can introduce gray struts. Gray struts are there. So later on in the chapter you will come to know about that. So that is one. And another is a displacement of the septum can result and the nose is exposed to further torsion forces during parturition, mostly when there is a face presentation. So face presentation is there. So in those cases, during childbirth, so the face gets compressed over the posterior part of the mother and may lead to compression. So that is one reason where you get a deviated nasal septum. So others are dislocations were more common in primipara when there is in the second stage of labor lasted for more than 15 minutes. So when the second stage of the labor lasted for more time, then there is a constant compression force over the pubis of the mother, or if it is a posterior position or face presentation over the sacrum of the mother, leading to compression of the nose, leading to a deviated nasal septum. So the normal septums will be like this. See, this is the septum and these are the turbinates. This is the anterior most part or the columnar part and this is the septum proper. So in left occipito-anterior presentations, the dislocations were generally to the right. And in right occipito-anterior presentations, the dislocations were to the left. So then that is the birth molding theory. Other causes trauma to the nose due to blow or sports injuries, repeated fall on the face during childhood may lead to dislocation of the quadrilateral cartilage from the maxillary crest. So the quadrilateral cartilage or the septal cartilage is the septal cartilage proper, which is attached inferiorly to the maxillary crest and the palatine crest. So due to trauma, there will be a dislocation of the septum from this crest of the maxilla and the vomerine groove. So posteriorly is the vomerine groove, inferiorly is the maxillary crest. So this quadrilateral cartilage can get dislocated from the maxillary crest inferiorly or posteriorly from the vomerine groove, leading to a deviation of the septum. And other is a crushing or blow from the front may cause buckling or twisting and fractures. And that is a trauma. So first is the birth molding theory, next is trauma to the nose, and next is the developmental error. So there is a due to an unequal growth between the palate and the base of the skull may cause buckling of the nasal septum. So DNS may be seen in patients with cleft lip and palate mental abnormalities. Other causes, septal deviations are associated with high arched palate. So whenever in childhood, if there is an adenoid hypertrophy, the child breathes to the mouth. So when the intraoral pressure is more than the intranasal pressure, there will be an high arched palate. So which may be acquired a high arched palate due to mouth breathing. So the intraoral, there is an imbalance between the intranasal and oral pressure. So the intraoral pressure is more than the intranasal pressure, leading to a high arched palate. So when the palate is high arched, definitely there will be a septal deviation. Okay. And others are racial factors where DNS is more common in Caucasians. Hereditary, there is a genetic predisposition as several members of the same family may have a deviated nasal septum. So understood the etiology of the nasal septum. So this much is the etiology of the nasal septum, not only a trauma to the nose. Understood? The site of the DNS. So depending on where the septal deviation is, you can have cartilaginous, bony, or both. So the deviation can include both the cartilage and the bony part, or either a cartilage or a bony part. And deviation may be anterior or posterior, and deviation may be a high or a low deviation. So depending upon the site, you may have so much. See, I told you previously, so this is the septal cartilage or the cartilage proper. This is the perpendicular plate of the ethmoid, bony part, and this is the inferiorly. Postero-superiorly is the perpendicular plate of ethmoid. Postero-inferiorly is the vomer, and this is the rostrum of the sphenoid. So this is the crest of the maxilla, and this is the crest of the palatine. So these are what make the septum. So the types of deviations, the types of deviations, they are either a caudal dislocation, deviations, or spurs. So caudal dislocation. So normally the anterior-most part of the septum is kept in the columella. So columella is nothing but skin with a fibrofatty tissue. So the anterior-most part is kept in the columella. So when this anterior part is either, if it is not kept in the columella, it projects either to the nostrils, either to the left or the right. So whenever you do a tip elevation, you can see a projecting part into the nostril, either right or to the left. So depending on to which side the dislocation is either to the right or the left. So the lower border of the septal cartilage is usually displaced from its medial position. So previous picture I showed you how the septum is in the midline. So if it is displaced from the medial position and projects into one of the nostrils, so that is called caudal dislocation of the septum. So this is better seen when the patient head is still little backwards and you do a tip elevation. Then that is a caudal dislocation. So deviations. So deviations may be either a C-shaped deviation or an S-shaped deviation. C-shaped or an S-shaped. By more generalized bulge, a C or S-shaped deviations occur either in the vertical or a horizontal plane. Either a C in the vertical plane, a C in a horizontal plane, or an S in the vertical or a horizontal plane. Depending on that, you will have a posterior or anterior deviation or a high or a low deviation. A C-shaped deviation, so both the cartilaginous and the bony septum is deviated to one side. So in a C, both the cartilaginous and bony deviations are deviated to one side. So one side there is a concavity and the other side there is a convexity. So the nasal cavity on the concave side of the septum is wider and may show compensatory hypertrophy of the turbinates. So when there is a long-standing obstruction or deviation onto one side, the patient gets accustomed to the obstruction on that side. So he may not feel obstruction on that side. So whenever there is a compensatory hypertrophy on concave side, he always complains that there is a the obstruction is on the concave side because of the long-standing deviation to one side. The patient gets acclimatized to that side and he may not feel any nasal obstruction on that side. Okay. So always he complains, oh, the obstruction is on this side, though the deviation on the other side. That is due to the compensatory hypertrophy of the turbinates. So in a S-shaped deviation, the septum shows S-shaped deformity and may cause bilateral nasal obstruction. So posteriorly, you will have a concavity to one side and a convexity to one side. So both a concavity and concavity to one side, either sides you have. So one side there will be a convexity and a concavity, and the other side also you will have a concavity and a convexity. So the person will have obstruction on both the sides. So bilateral nasal obstruction will be there. And spur, what is a spur? It is a sharp angulation at the bony cartilaginous junction. So it's a shelf-like projections or sharp angulations at the bony cartilaginous junctions. That is either a chondrovomerine junction, which is posteriorly, or a chondroethmoid junction. So posteriorly, the bone is there between the cartilage and the bone. You may have either a chondroethmoid junction or chondrovomerine junction. And inferiorly at the maxillary crest also you may have an angulation. So whenever there is a blow on the face, so the cartilage gets either it may get fractured or it bends, and there is a dislocation at the bony cartilaginous junction, and you may have a sharp angulation. So that is a spur. It is a sharp angulation or a shelf-like projection at the bony cartilaginous junction, either the chondrovomerine, chondroethmoid, or the cartilage and the maxillary crest. See, you can see this is the caudal dislocation to the left. So whenever you do a tip elevation, so normally it should be kept in this columella. The anterior most or the caudal part of the septum should be kept in the columella. So when it is not kept properly in this, so it may get dislocated into the either of the nostrils. So here we call it the caudal dislocation of the septum to the left. See, it should be kept in this groove, this caudal part of the septum. So when it is not kept in this maxillary groove, then it may get dislocated to one nostril or the other. So this is called the caudal dislocation. So spurs are usually the result of vertical compression forces. I told you a blow, okay, may result in the spur. The fractures through the septal cartilage may also produce spurs, as I told you previously. The fracture of the cartilage produces. And a spur may press on the lateral wall and gives rise to headache. So it may press on the lateral wall and it may give rise to a headache, and it may lead to epistaxis also when a vessel is passing over the spur. Because of the stretch of the vessel, it may lead to recurrent epistaxis. So may give rise to recurrent epistaxis from the vessel stretched on the spur. Then other deviations are thickened septum and crooked septum. So the deviations are of 5 types. One is dislocations, deviations, spur, thickened septum, and crooked septum. So thickened septum thickening may be due to organized hematoma or overriding of displaced septal fragments. So either when there was a hematoma previously, and if it is not drained properly or not treated properly, so the hematoma may get organized and you may have a thickened septum. Or when there is an injury due to a fracture and overriding of the two segments, you may have a thickened septum. And next is a crooked septum. Crooked septum is there no certain shape to the septum. So it can be deviated to any form. So there's an unexplained gross septal deformity following trauma. So septal deviations are frequently associated with anatomical abnormalities in adjacent areas. So adjacent area, if there is any anatomical abnormality, like if there is a concha bullosa. Concha bullosa is nothing but a pneumatized middle turbinate. So if there is a big pneumatized middle turbinate, what it will do, it will deviate the septum to the other side. So like that, if there are any anatomical abnormalities also may lead to the deviation of the septum. So in the lateral nasal wall, a compensatory hypertrophy of the turbinate or an ethmoid bulla occurs on the concave side of the nasal septum. So if it is there, there will be a deviation to the other side. So see, you can see this is a C-shaped deviation. So where the bony and the cartilaginous parts are deviated to one side. So this side there is a deviation and this side there is a compensatory hypertrophy of the inferior turbinate. To compensate for the increased space, the inferior turbinate gets hypertrophied. So whenever you correct the deviated nasal septum and put it into a straight line, then you need not correct the inferior turbinate, hypertrophy of the inferior turbinate, automatically it get regresses. So the compensatory hypertrophy of the inferior turbinate get regresses automatically when you correct a septal deviation. So you need surgery when you do a surgery for a septal deflection. See, there's an S-shaped deviation. See, you will have a concavity on this side and a convexity. So there is a concavity and convexity on this side, and there is a concavity and convexity on this side. So that is a S-shaped deviation. So this is a septal spur. So septal spur, what we told, it's a sharp angulation or a self-like bone to one side. At the either you may have here you may have a spur or here posteriorly you may have a spur. So almost touching the lateral wall of the nose. So sometimes you may have touching the lateral wall. It may block the osteomeatal complex leading to headache, or it may compress the anterior ethmoidal nerve leading to anterior ethmoidal nerve syndrome or a Sluder's neuralgia, or a vessel passing over the septum gets stretched and frequently injured, leading to recurrent epistaxis. So that is why you have to treat a spur, septal spur. So this is how the external nasal pyramid will be. So this is the bony part and this is the cartilaginous part. So this is the bony part of the external nasal pyramid. So this part is the bony part and this is the cartilage. So this is this part and this is the cartilaginous part. So anterior septal deviations are often associated with deviations in the external nasal pyramid. So sometimes the septal deviations can also get associated with deviations of the external nasal pyramid also. In such cases, you have to correct the external nasal pyramid also. Otherwise, you may have a change in external appearance of the nose. So deviation may affect any of the three vertical components of the nose. So this is the bony part, cartilaginous part, and this is the caudal part of the septum. So here you can see there is a straight bony part. So external nasal pyramid, the nasal bones is straight and there is a deviation of the cartilaginous pyramid. See, so the anterior caudal part of the cartilage is also in the same line with the anterior part of the cartilage. Okay, so there is a bony pyramid is in straight line and there is a deviation of the cartilaginous part towards left. See here you can see there is a C-shaped deviation, the deviation of the upper bony part, bony septum, upper bony septum, there is a deviation of the bony part and here there is a deviation of the cartilaginous part also. See the bony part is deviated to right, cartilaginous part is deviated to left. See here you can see a S-shaped deviation where the bony part is deviated to right The cartilaginous part is deviated to the left, opposite side. Okay, and the caudal part is deviated to the other side. So this is a S-shaped deviation. So the deviation of the middle third upper cartilaginous vault and septum is opposite to that of the upper and lower thirds. So effects of the septal deviation. So now all we taught about the types of deviations of the septum, etiology, and what effects you get with the septal deviations. So a compensatory hypertrophy of the turbinates on the opposite side can occur, as we told. So when there is an obstruction on one side, there is a roominess of the other side. To compensate for that roominess, the inferior turbinate hypertrophies. So there is a compensatory hypertrophy. A C-shaped deviation is associated with hypertrophy of both the inferior and middle turbinates on the concave side. So in the previous picture, we have saw there is a deviation like this, and the middle and the inferior turbinates hypertrophy. Generally, the inferior turbinate only hypertrophies are due to a recurrent rhinitis or all. There will be edematous because of the middle turbinate. That's all. Other than when there is a concabulosa, there won't be a hypertrophy of the middle turbinate. There will be hypertrophy of the inferior turbinate. S-shaped deviation is associated with inferior turbinate hypertrophy on one side and middle turbinate on the other side. So an external deformity, the deviation involving junction of the septal cartilage with upper lateral cartilages can lead to external deviations. So when a deviation is involving the septal cartilage and the upper lateral cartilage at the junction, if there is a deviation, it can lead to external deviation. The caudal dislocation with subluxation of the septal cartilage or the maxillary crest leads to tip deformity and columellar retraction. So when there is a caudal dislocation with subluxation of the septal cartilage, means so the septal cartilage is kept in the groove of the maxilla and the palatine bone. So if it is dislocated from that, then you will have the tip deformity and columellar retraction will be there. Then next, what the other effect is as an impairment of drainage to sinuses due to blockage of the osteomeatal complex. As we told, because of the deviated nasal septum, which may lead to recurrent rhinitis, which leads to edema of the mucosa, leading to blockage of the natural ostia of the sinuses, which leads to stagnation of the secretions of the in the sinuses, leading to inflammation of the sinuses, which is nothing but sinusitis, or a spur, which is causing a blockage of the ostium, leading to stagnation of the secretion and sinuses. So these are the different ways how a deviated nasal septum can lead either directly blocking the osteomeatal complex and leading to stagnation of the secretions and inflammation and sinusitis, or a deviated nasal septum leading to a recurrent rhinitis causing edema of the mucosa, nasal mucosa and osteal mucosa, and blockage of the osteomeatal complex. And leading to an impairment of drainage of the sinuses. Okay, so leads to sinusitis. So that is one. And another is a secondary atrophic rhinitis on the rheumatic side. So most of the times you may have a hypertrophy of the inferior turbinate on the rheumatic side. At times, if there is still rheuminess on the other side of the deviation, you will have atrophic rhinitis. So physiology, probably you are already taught the functions of the nose. So the main function of the nose is thermoregulation of the or air conditioning. Whenever we take in air, so the dry air, uh, the the moisture is added to the dry air. So the mucosa, the function of the mucosa is that it adds moisture to the dry air so that you will not have crusting in the lower respiratory tract. So that is a function. So if the mucosal lining, the area, surface area of the mucosal lining is decreased due to roominess of the other side of the nasal cavity, you will have dry air. So which leads to secondary atrophic rhinitis. Understood? So again, in the atrophic rhinitis chapter, you will get much more detail about this. So clinical features. So there will be a nasal obstruction, either a unilateral in a C-shaped, bilateral in a S-shaped deviation, a paradoxical nasal obstruction. Patient, that is what I was telling you previously. What is that paradoxical nasal obstruction? So patient complains of unilateral nasal obstruction on one side and anterior rhinoscopy reveals septal deviation onto the opposite side. That is what I was telling. So whenever there is a long-standing deviation to one side, the patient gets accustomed to that side obstruction. So he doesn't feel that there is an obstruction on that side. So because of the roominess on the other side, there will be a hypertrophy, compensatory hypertrophy of the inferior turbinate. So he keeps on telling that there is an obstruction on the other side of the deviation. So when you examine, you see a deviation onto this side. So most of the patients, we get the same complaint. We say, you are getting any obstruction onto the right and the deviation onto the right. He says, no, I can breathe properly on the right. On left, I'm having obstruction. So that is called paradoxical nasal obstruction. So what is paradoxical nasal obstruction? It is a patient complains of unilateral nasal obstruction on one side. An anterior rhinoscopy, when you examine, it reveals that the septal deviation is onto the other side. Then the patients have a long-standing fixed, that is what the explanation is, the long-standing fixed unilateral nasal obstruction to which they are accustomed and they are no longer aware of it. So whenever he gets any cold, there'll be a hypertrophy of the turbinate on the left. So he will feel the obstruction on the left, though the main cause is a deviation on the right. Okay. So the mucosal swelling associated with the nasal cycle results in intermittent nasal obstruction on the wider side of the nose, and this becomes the dominant symptom to be appreciated by the patient. Then site of obstruction. So either a vestibular is a caudal septal, in the vestibular region, the obstruction is due to a caudal septal dislocation, synechiae or stenosis of the anterior nerves. Nasal valve area. So nasal valve area, what is the nasal valve area? So that area corresponds to the anterior part of the inferior turbinate, laterally, medially the septum, and above the Lyman nasal. Lyman nasal is between the upper and lower lateral nasal cartilages. That is a Lyman nasal. So here, if there is an obstruction, that is a nasal valve area. So medially the septum, laterally the anterior end of the inferior turbinate, and superiorly the Lyman nasal. So the obstruction of the nasal valve area, post rhinoplasty, synechiae, if they are not post of follow is not good, you may have synechiae. And attic, upper part of the nasal septum. Attic is the upper part. So always attic wherever, either in the middle ear or the nose. Attic means upper part. So upper part of the nasal septum due to IDNS. Then turbinate, that is hypertrophic turbinates, concabulosa. Other is coinal atresia or coinal polyp, intracoinal polyp. You may have obstruction at the coinal part. So these are the various parts of the nose where you may have obstruction due to the reasons. So what is Cottel's test? Cottel's test is, so septal deviations in the region of the nasal valve area cause the greatest obstruction because it is the narrowest part. Nasal valve area is the narrowest part of the nasal cavity. So again, I'm telling you, nasal valve area is laterally by the anterior end of the middle turbinate, medially by the septum, and superiorly by the Lyman nasal. This is the narrowest part of the nasal cavity, which is called a nasal valve. So whenever the septal deviations in this region of the valve cause a greatest obstruction. So because this is at the narrowest part of the nasal cavity. So to detect the obstruction, either is in the nasal valve or not, the Cottel test is done. So the Cottel test is done to detect whether the nasal obstruction is at the nasal valve or not. So it will confirm the fact that the obstruction is in the valve. So it is a simple and useful test which you have to do normally when you are given a case of the deviated nasal septum. You have to do the Cottle's test and mention the Cottle's test. So patient's cheek is retracted upwards and laterally. So the cheek is retracted. So you should not pull here wrongly. It is printed here. It is retracted. Cheek is retracted upwards and laterally. Then the patient will be relieved of obstruction or the blockage. He will feel better to breathe. The blockage is decreases. That means the obstruction is at the nasal valve area. So the patient pulls, not pulls, it is retracted, cheek is retracted upwards and laterally, opens up the internal nares and thus reduces the blockage. So that shows that the obstruction is at the nasal valve area. So if the improvement of nasal airway on the test side, that means test is positive, Cottl's test is positive. If there is an improvement of air when the test is done. So it indicates abnormality of the vestibular component of the nasal valve. So in these conditions, you will do a septoplasty because the deviation is in the anterior part of the septum. So whether you do a septoplasty or SMR depends on the deviation of the nasal septum. So this is how the Cottle's test is done. Retraction of the cheek upwards and laterally. There will be improvement of obstruction. That means Cottle's test is positive. Excuse me. So septal deviations in the newborn are associated with asymmetry of the nostrils or oblique columella and tip. So most cases are diagnosed by anti-rhinoscopy and the use of raised struts. So you will have raised struts pin type. So you can introduce into the nostril and see whether there is a obstruction or not. So these gray struts are there 4 mm wide and 2 mm thick. After lubrication are inserted into the nostrils and then gently pushed backwards along the floor of the nose, hugging the septum. So normally the struts can be introduced for a distance of 4 to 5 centimeters. So in adults, the nasal cavity length is around 5. So in children, it is still less. So you can introduce it up to 4 to 5 centimeters. So in cases of septal deviations, a frank obstruction. So when you pass this along the nasal floor, if there is a deviation, so there will be an obstruction at one part where you cannot put the strut further forwards, you cannot introduce it. So in cases of septal deviation, the frank obstruction is encountered usually 1.5 to 2 centimeters back from the nostril. So most reliable test and is well tolerated during infancy. So other is a compression test. The nasal tip is pushed backwards. If there is a septal dislocation, it will collapse against the philtrum of the upper lip. So in newborns, to see whether there is a nasal deviation or not, you can use these methods, either using a gray strut, so where it cannot pass further than 1.5 or 2 centimeters, and a compression test. Then next, this is all the obstruction what we are talking about till now. Now headache. So DNS with a spur may press on the lateral wall of the nose, giving rise to the pressure headache or a vacuum headache. So usually occurs due to associated sinusitis. See, you can see in this picture how the gray struts are being introduced. So there's a neonatal septal deviation on the, see, you can see on the left side, on the right side, the strut could be introduced for a far apart or longer part. See, in the left side, you can see most of the strut is remaining outside. See, it cannot be introduced more than 1.5 or 2 centimeters further. So there is a deflection of the nose on the left side. See, you can see the left splint is longer or remaining outside. Larger part is remaining outside. It's not being introduced inside. So other is an anterior ethmoidal nerve syndrome or Sluder's neuralgia. So what I told you previously, a pressure exerted by septal deviations on adjacent sensory nerve can produce pain. That is called anterior ethmoidal nerve syndrome or Schluter's neuralgia. Next is, so first we saw an obstruction, next we saw headache, next sinusitis. So deviated nasal septum causes obstruction of the sinus ostia, which leads to poor ventilation of the sinuses and leads to sinusitis. So when there is an obstruction of the ostia, whatever the secretions in the sinuses, they are drained by so many manners. Each sinus has so many manners, star pattern, stellate pattern, like that. So they are by the ciliary activity, the mucus blanket is brought up to the the ostia of the sinus, then into the meatus, then posteriorly it goes into the nasopharynx and the throat. That is a normal process. So whenever the ostia is blocked, what will happen? All the secretions get stagnated inside. So when there is a stagnation of secretion, there is infection, and that is called sinusitis. Inflammation of mucosal lining of the sinus is called sinusitis. So you will develop sinusitis. And next is epistaxis, usually due to spur or crusting of the nasal mucosa. So spur, due to spur, as already we have spoken, stretching of the vessels lead to, if there is a recurrent inflammation, infection or trauma, you will have epistaxis. Due to stretch of the vessel, it gets easily broken away. Then any formation of crust, as in atrophic rhinitis, if there is a crust formation, whenever you try to remove the crust, you will have epistaxis. So there is other condition or which you come across clinical feature is a hyposmia or anosmia. They are very rare. So if there is a recurrent rhinitis, you may have a hyposmia. Very rarely anosmia. So failure of the inspired air to reach the olfactory region may result in partial or total loss of sense of smell. So if there is a deviation, so these olfactory nerves, they are in the upper part of the nasal septum adjacent to the upper part of the middle turbinate. So where? So if there is a deviation, so when the inspired hair does not reach that area, you may not be able to detect the sense of smell. Then external deformity, septal deformities may be associated with deviation of cartilaginous or bony dorsum or both, as previously we have saw in the pictures. And medullary infection, so whenever there is a deviated nasal septum, it predisposes to medullary infection because the eustachian tube is present in the nasopharynx, lateral part of the lateral wall of the nasopharynx, which is posterior to the inferior turbinate. So whenever there is a recurrent sinusitis, you will have postnasal dripping. So which leads to the inflammation of the medial end of the eustachian tube or the pharyngeal tube, causes edema and blockage of the eustachian tube. So whenever there is a blockage of the medial end of the eustachian tube, which balances the external and the pressure in the external and middle ear. So there will be negative pressure. Whatever air is in the middle ear, it gets absorbed. So there will be negative pressure in the middle ear. So understood, when there is a blockage of the eustachian tubal orifice, the medial end of the eustachian tubal orifice. So whatever air, the function of the eustachian tube is to balance the pressure between the external and the middle ear. So whenever there is a blockage, whatever air is in the middle ear, that gets absorbed. So there will be a negative pressure in the middle ear. So due to the negative pressure, there will be transudation or exudation of secretions into the middle ear by the mucus secreting glands in the middle ear. So that is called non-suppurative otitis media or otitis media with infection, with effusion. So whenever there is an ascending infection through this middle eustachian tube, these secretions which are sterile gets infected. Then it leads to acute suppurative otitis media. And if it is not treated on time, it gets away through the makes a perforation in the tympanic membrane and all that discharge comes out. That is acute suppurative otitis media with complication. Means there is a perforation. So when this is is not treated, or if this condition persists for more than 3 months, it is called chronic suppurative otitis media. So due to this deviated nasal septum, also you will have medullary infection. So when there is any case with a deviated nasal septum with a CSOM, first you have to correct the deviated nasal septum and then you have to correct the CSOM. Otherwise, again, you may have a, if you do a meringoplasty or tympanoplasty without correcting the deviated nasal septum, again, you may have a perforation. So that is also one of the causes for having a perforation, recurrent. So investigations, what all you'll do is you'll see a hemoglobin, bleeding time, protein, blood investigations, hemoglobin, bleeding time, clotting time, platelet count, X-ray paranasal sinuses, Waters view or occipitomental view or Waters view. So with open mouth, it is Pierce view to see the sphenoid sinuses. With open mouth only, you can see the sphenoid sinus. So this is the X-ray paranasal sinuses. You can see the any bony part of the deviation. You can see or any inflammation or sinusitis you can see in this X-ray. So alignment of the septum, haziness of the sinuses, assessment of the size of the turbinates can be seen in the X-ray of the paranasal sinuses. Then still, if you want to get much more better study, you can go for a CT scan of the paranasal sinuses. There you'll have evaluation of all the sinuses, including the pathology, status of the osteomeatal complex, presence of concha bullosa, attachment of the unsnared process, whether there is a medial or lateral attachment. Then, then next is a diagnostic nasal endoscopy. You can do a rigid nasal endoscopy and directly you can see where the deviation is and any other, whether there is any osteomeatal complex block. So pathology, the site of pathology you can see. Okay. Hello. So some disturbance coming from your side. Someone's, please take care. So a precise identification of a pathologic site you can make out in a CTPNs, in abnormalities of the septum and osteomeatal complex, and anatomical variations. All these you can diagnose by doing the diagnostic nasal endoscopy. So treatment, medical treatment is only for the associated rhinitis or sinusitis. Surgical treatment is septoplasty, submucous resection, endoscopic septoplasty, septorhinoplasty. So if there is an external nasal deformity along with the deviated nasal septum, you will do a septorhinoplasty. So septoplasty, if you do when there is an anterior deviation of the septum or the cartilaginous deviation, and submucosal resection you will do when there is a posterior deviation of the septum. So you know there is a what is Cottel's line? Cottel's line is an imaginary line drawn from the nasal spine of the frontal bone to the nasal spine of the maxilla. So any deviations anterior to this Cottel's line, they are called anterior deviations, and deviations mainly due to the cartilage. And any deviations posterior to this Cottel's line, they are called posterior deviations, and mainly they are due to the bone. So these anterior deviations are corrected by septoplasty and posterior deviations are corrected by submucosal resection of the septum. So that is the importance of the Cottel's line. Okay. Then, so the Cottel's, so with Cottel's, so many are there. Cottel's surgery, Cottel's line, Cottel's test, Cottel's classification. So here again the Cottel's classification of the septal deviations. So Cottel divided the septal deviations into simple deviations, obstructive deviations, and impactions. So simple deviations where there is a mild deviation of the septum, there is no nasal obstruction and no surgical treatment. Obstructive type, more severe deviation of the septum. It touches the lateral wall of the nose. On vasoconstriction, the turbinate shrinks away from the septum and relieves the nasal obstruction. Somewhere I'm getting a disturbance. Please, can you, whoever is disturbing, please, can you, or otherwise I will stop the class.
ఎవరిని ఇన్వైట్ చేయరా
So obstructive type, more severe deviation of the septum, which touches the lateral wall of the nose on vasoconstriction. That is on putting a cotton wool with adrenaline. If the turbinate strings away from the septum and relieves the nasal obstruction. This is obstructive type. An impacted type is very marked
నేనే
deviation of
రా
the septum,
కాకపోతే ఫోన్
where
మాట్లాడుతున్నాను
when you put a cotton wool
చెప్పరా
with with adrenaline for vasoconstriction, so it is not relieved of obstruction. This is called impacted type. So Cottle divided the obstructions into simple, obstructive, and impact. So surgical treatment is indicated for some of the obstructing type and most of the impacted. So simple deviations do not require any surgical treatment. Some of the obstructive type of deviations require, and all of the impacted type require surgical treatment. So the essential indication is a bony septal deviation. So an ideal septal surgery should satisfy the following criteria. It should relieve of the nasal obstruction, should be conservative, should relieve all the contact areas, should not compromise the osteomeatal complex, should not produce iatrogenic deformity, should give a scope for revision surgery. So if required at a later time. So surgically, the septum is divided into anterior posterior segments by a vertical line, what I told you, that is the Cotton's line. So deviations anterior to this treated by septoplasty and posterior by SMR. So septoplasty, a conservative approach to septal surgery where most of the septal framework is retained. Only the most deviated parts are removed. Rest of the septal framework is corrected and repositioned in the midline. So the indications is deviation with persistent nasal obstruction, DNS with a spur causing recurrent epistaxis, DNS causing sinusitis as a part of septorhinoplasty. So contraindications are acute nasal or sinus infections. So bleeding diathesis. So whenever there is a prolonged bleeding, that's why you have to do a bleeding time and a clotting time platelet count. So when there is a prolonged bleeding or clotting time, you should not do. And in diabetes and other systemic diseases, there are contraindications. So anesthesia, I think the surgeries of the septum we can take in the next class. Okay. What we'll do, shall we complete or we'll take in the next class? Surgeries of the septum. What shall we do? Shall we continue or can we stop? So anesthesia, either local or general anesthesia you can do. Position is a Proed's position, that is 15 to 20 degrees elevation of the head end elevation, that is called a Proed's position. So you have to pack the nose 15 to 20 minutes before the operation with half an inch ribbon gauze soaked with xylocaine and adrenaline. So xylocaine acts as an anesthetic and adrenaline acts as a vasoconstrictor and increases the action of xylocaine. So that is the importance of xylocaine with adrenaline. So it increases the action of xylocaine. So prolongs the action time of xylocaine. Then the patient is placed in Proed's position with the chin and external aortic canal, external aortic meatus in the same vertical plane. That is 15 to 20 degrees of head end elevation. We will take in next class. Okay. So surgeries of the septum we can take in next class. Okay. Thank you. Any more doubts up to here? Any doubts you have? If you have any doubts up to this part of the class, I can tell you. If you have any doubts are there, you can please put on the chat. Okay then, thank you. Ma. Stop share.
Start.
Then you cut.